هو دكتور فرح.
Uh, yes, sir. Assalamu alaikum, sir. Yes, sir. I'm good. Thank you, sir.
وعليكم السلام. How are you?
Yes, sir. I'm good.
We should start in 3 minutes. So today
Okay.
we join a little bit late, but we still have time.
Sir,
We are waiting now for Dr. Abdul Latif.
do you go
What,
through
Dr.
my
Farah?
slides, sir? And it's okay?
Yes, I
Okay.
go through. It's much better. Yes, this section photos with the good explanation will be very very nice.
Okay,
So
sir.
thank you very much. Okay. Dr. Abdul Latif still not join. You contact him. Ahmad, if possible, if you can make participant can connect directly. Do not put them in a waiting room. I think it will be better.
Sorry, sir.
If you can make the participant join directly, no need for waiting room.
Yeah, sure.
Thank you. We should start now, but we will wait for 1 or 2 minutes for Dr. Abdul Latif and Dr. Yasser until they join. Then we can start with Dr. Farah. Okay, Dr. Farah?
Yes, sir.
Dr. Yasser, how are you, Dr. Yasser?
Hello.
Dr. Abdul Latif, you are muted, Dr. Abdul Latif. Unmute. دكتور عبد اللطيف افتح الصوت يا دكتور، الصوت لانه ايوه تمام.
الآن كيف؟
الان تمام كويس ممتاز. So Dr. عبد اللطيف, you can start. We will start with Dr. Farah. You can welcome the audience and introduce
Oh,
Dr. Farah to start. Okay?
okay, تمام. Welcome, Dr. Farah, and we start with Dr. Farah about anatomy of accessory and hypoglossal nervus.
Thank you very much for giving me the opportunity, and thank you the WFNS and also the Yemen Young Neurosurgery Society to organize this workshop. Thank you very much, sir. So I
Thank you
will
very
share
much,
my
Dr. Farah.
screen. So please let me know if my screen is visible and
Yes,
everybody
it's
can see it.
perfect.
Yes, sir. Thank you. So 11th nerve is accessory nerve. This is a cranial part, coordination of the cranial nerve. So although it is started from the spinal root, but I just take this image just to again recap our all the cranial nerve and where is our today's study is about the accessory nerve 11th and the hypoglossal is the 12th. So again is the cranial nerve and where it is originating and where it is located, actually better to say, on the cranium. This is a visual impression. So the 11th cranial nerve is known as the accessory nerve, which is primarily motor and both spinal and the cranial components. So it innervate two muscles, sternocleidomastoid and the trapezius muscle, which are essential for the head rotation, shoulder elevation, and certain neck movement. And the cranial part of the accessory nerve is often considered as a part of the vagus nerve and contribute the motor innervation of the muscle to the soft palate, pharynx, larynx, and adding to the phonation and swallowing. And sensory fiber is from the cervical plexus and it joined with the 11th nerve and providing some sensory input to the target muscle. So this is a visual impression of where this nerves is supplying. So it is sternocleidomastoid and trapezius, and there are also some muscle of the tongue. I find this picture is very interesting and I think it is very informative for anybody who want to correlate with the anatomy, and it is just a blick that all the nerve and where is most important muscle innervations and the sensory innervation. So I think this is a very good takeaway picture for all the cranial nerve. I will explain and stick to our study today. So it is the pathway of the accessory nerve, and it is how I said it is a spinal root originate. It is from C1 to C5, or some variation is also possible, and in that case, it is cervical 1 to cervical 6. And the fibers from the spinal cord is ascend through the foramen magnum into the skull and then exit the skull through the jugular foramen along with the vagus nerve. And after existing the skull, the nerve descend and innervate the sternocleidomastoid and the trapezius muscle, which is superficial. So this is a image, actually, what I just said that it is a cervical pathway. So it is it takes it origin from the cervical 1 to 5, and it's go up and it's go through the in the cranial part is on the to the jugular foramen, and then it's coming out and it's supplied to the sternocleidomastoid and trapezius and also the small muscle of the tongue. So this is also an image reflect of the accessory nerve and the vagus nerve and the origin, where it is, and then it is coming out from the jugular foramen and then supplying the sternocleidomastoid and the trapezius muscle on the back. And it also shows that they are having like the it is coming out through with the vagus nerve through the jugular foramen. So why actually we are learning the origin, pathway, and clinical orientation of the anatomy is why so important? Because the patient come with the symptom. Patient can't say us, I have accessory nerve injury. So patient come with some symptom, and we as a doctor should analyze the symptom and should pinpoint that which nerve innervation is disturbed. So injury to the accessory nerve is result to the weakness and the paralysis of the trapezius and the sternocleidomastoid, which is leading to the difficulty of the shoulder elevation and impair also the head rotation and scapular wing and head dropping. So lesion may occur due to trauma, surgical injury, like on the posterior triangle of the neck, tumor, or when it is for the radiation hazard. Isolated injury, like as I say, isolated means one-sided. If it is injury, then patient come with one side shoulder paralysis, and the motor innervation is bilateral, and it is from the supranuclear level. So the unilateral is always give a light symptom, whereas the bilateral symptom is more prominent. And injury can be produce noticeable functional deficit. That means dystonia, neck and shoulder muscle rotation, or the drooping of the shoulder, or the patient can't shrug the shoulder. So this kind of symptom patient will come. This is very important picture for the anatomical correlation to understand when we dissect the nerve, how it's actually look like when we are dissecting. So as I said about the origin, that it is coming from the C1 and C2, and it comes upward, and the cranial part is coming through the jugular foramen. So it is a image reflect. There is another dissection picture of the accessory nerve, that the spinal part is originating and it is going through to the cranial part. This is again for the image correlation, that what is happening on the spine, so that we always correlate with the image what we see in the book, and when we are dissecting and the operative field, it should be always correlate. So it's just an easy image reflect that what I just said, that it is the spinal part is coming from the C1 to C5, or in variation C6, and it's coming up to the skull and exit the skull through the jugular foramen. So this is a correlation. Another image and dissection, and this is very important, so that what we see in the book when we are dissecting, we can also correlate on the patient or the operative field, or when we are dissecting in the anatomy in the cadaver. All is very important to understand, not only the book image, but also to find out the structure in the dissection. So here is very nicely, it is present that the sternocleidomastoid is already is just a level up. So it's like if we take the sternocleidomastoid here, so this triangle is showing us that where is our nerve. So here we can see that accessory nerve and the sternocleidomastoid. So here if we see the sternocleidomastoid, so this is our nerve. Another anatomical dissection to recognize the nerve. So the spinal component, and it's also supraclavicular nerve and external jugular vein and greater auricular nerve and trapezius muscle. So this correlation is very important because it's not only detecting the accessory nerve or detecting the sternocleidomastoid or trapezius muscle, but also to be very careful about the other surrounding structure, because injury to the surrounding structure will also manifest clinically, and that is actually the complication. So not only recognizing the accessory nerve, but also understand the surrounding structure and memorize by heart is very important. So this is the spinal accessory nerve, and on the top we have the laryngopharyngeal. This is also a dissection picture of the accessory nerve, and I find this picture very interesting because it's already said which is medial, lateral, and superior and inferior. That also help us to correlate the image what we learn from the anatomy book and actually what we see when we are dissecting a cadaver or on the living patient. So how I just said the spinal component C5, 6, and it is go up, and it's also here is the hypoglossal nerve, and this is a correlation of the muscle as well, so that we understand that where the nerve is going up, and from the jugular foramen how the nerve is also commonly coming up with the hypoglossal nerve. This is a image a reflect of the two like vagus and the accessory. So how we already saw in the dissection that it is very close to the internal jugular vein. So the cranial root of the accessory nerve is coming out, and it's all are coming going through to the jugular foramen. So it is also parallel to the vagus nerve. So it's showing a very nice anatomical correlation of the surrounding structure. Again, this is a radiological picture like CT, like MRI. If we see that where is our book image, so I suggest that if it is possible, always correlate with the book image with the practical image. That means MRI, CT scan, or dissection picture, so that one can really have a deep memorization of book image and while it is dissecting or operating. So if we know that the back long muscle is the trapezius and the front is the sternocleidomastoid, and in between the external jugular vein. So if we can see that on the picture as well, that where is our, here is the trapezius muscle. If we just reflect that this is our trapezius muscle and this is our cervical vertebra, and from here is the internal jugular vein. So we can really correlate this picture with this radiological image. This is also our famous book, Neater. I take the picture because I find it very interesting. Whenever it comes for the neck dissection, it can be only even a lymphoma dissection, or maybe a local swelling. It can be a lipoma. It can be lymph node. One should really understand the anatomical correlation, because it seems maybe lymphoma or lymph node is very simple dissection or very simple small operation, but one should have clear idea about the anatomical correlation, that what are the structure I am expecting after going through the skin, superficial fascia, and the platysma, and what else structure one should recognize. And that's how we can coming up to the less surgical complication. That means we can also be very careful about before extracting anything, or abscess drainage, or lymph node as a biopsy, or lymphoma excision. So the anatomical correlation is very important. So it is started from the superficial, like if we see that this extension of the neck is for the trapezius and front is the sternocleidomastoid. So from the mastoid is the upper triangle. Then if we start the dissection, so it is a very good dissection picture that after skin we get some subcutaneous fat, and then the superficial veins are visible, whereas muscle is not yet dissected. And when we dissect the muscle, then it is very much visible, the trapezius, sternocleidomastoid, and then external jugular vein. And then it is very easy for us to recognize the nerve, vein, and the artery. This is the dissection picture, but is like more close up, just to correlate. Again, we dissect from the mandible as a like bony structure, if we just recognize as an anatomical landmark, and then when we dissect, we can find the accessory nerve and the sternocleidomastoid and the trapezius and the internal jugular vein. This is the spinal component, and it is coming up to the cranial part, to the jugular foramen. This is also a very important picture because this is a correlation with the hypoglossal and the vagus nerve, which we already see in the image, and this is a dissection correlation. So that's how I want to finish my the accessory nerve part. I should go quickly to my next slide presentation, and that is on the hypoglossal nerve. So hypoglossal is the 12th nerve.
We have 5 or 10 minutes, okay?
Yes, sir.
You have
Sir.
10 minutes, okay, Dr. Farah, because we have 10 minutes time, yes. Yes.
Okay, sir. I will try.
So we can have time for next speaker, yes. Thank you.
Okay, sir. I will finish it quickly, sir. So I will escape most of the time. Okay, sir. So the hypoglossal nerve is only the motor innervation, and there is no sensory and the parasympathetic component. So it is located on, the nucleus is located on the medulla oblongata, and it's midline between the pyramid and pyramids and olives, and the fibers emerge. Yes, please.
Did you open the screen share of the second slide? Because we only see the previous slides.
Okay, sir. Wait a second, sir.
We don't see the slides of the hypoglossal nerve. Yes.
Okay, sir. I understand, sir. Is it visible now, sir?
You can exit screen sharing and share again. No, I don't see it. I only see the screen of the previous lecture, 11th nerve.
I will start
Okay.
again, sir.
Okay, that will be good.
Now it is visible, sir?
Yes, now it's visible.
Okay, sir. Thank you, sir. Thank you.
Perfect.
Okay, so I will go fast because I have only 10 minutes. So the hypoglossal nerve are the only pure motor, no sensory and parasympathetic component. So the nucleus is origin from the hypoglossal nucleus located on the medulla oblongata. near midline between the pyramids and the olive, and the fibers emerge as a rootlet that converge to form a single trunk and exit the skull through the hypoglossal canal. So hypoglossal nerve, hypoglossal canal, it is very easy to memorize. Now we come through to the image that where is the hypoglossal nerve, where is the accessory nerve, and what I just described, that it is coming through to the single trunk, and then it is supplying motoric, only motoric intrinsic muscle of the tongue and the extrinsic muscle of the tongue. So it originates from the hypoglossal nucleus, exit from the hypoglossal canal, and lateral relation is very important, lateral to the internal carotid artery and medial to the internal jugular vein. So when I was in a medical school, I always remember vein, like vein, artery, and nerve. That helps me to remember this correlation. So there are 4 branches, meningeal branches, descending branches, and thyroid branch, and the muscular branch. So here is the image to see that the meningeal nerve, which is supply the meninges near the canal, and the descending part is coming to the C1, 2, and 3. So the muscle innervation, because it's purely motor, so is muscle of the tongue, genioglossus, hypoglossus, styloglossus. Why is glossus? Because Latin glossus means tongue, and the intrinsic muscle of the tongue. And it's the movement of the tongue, that means articulation, mastication, and swallowing. Why actually it is important? Because the affected side can be, the tongue can be atrophy or fasciculation, that means the involuntary fast movement of the tongue, and where we can see stroke, motor neuron disease, neck trauma, or the surgical injury. And same as unilateral damage are the more like the have less symptom than the bilateral damage. This is a image correlation of the tongue deviation and where is affecting the unilateral. So the tongue deviation is only on the one side. This is a anatomical dissection of the hypoglossal nerve. So these are all the muscle. I have better picture. So this is the dissection picture, just to correlate that where is the hypoglossal nerve, where is the facial nerve. And we are again taking the mastoid, the sternocleidomastoid and the hyoid bone as an anatomical structure, and then from there we can correlate to the other surrounding structure. This is also the anatomical dissection of most of the cranial nerve, and also the correlation of the cranial nerve. This is very important anatomical structure. Also the triangle where is we can see the vagus nerve and the pharyngeal vein and the hypoglossal nerve. This is the image, and how we can correlate on the dissection. So I put the image here so that it is very easy for the students to correlate with the dissection table. This is very interesting image reflect because it's like correlation of the anterior, posterior, superior, and the inferior structure. Once we can find out the muscle, then it is easily possible that we go through the muscle or the submandibular gland or the hyoid bone as a main anatomical landmark, or thyroid cartilage. Then when we deep dissect, then we can find out the hypoglossal nerve. This is also a dissection picture of hypoglossal nerve, and also the correlation with the vagus nerve and the internal jugular vein. So this is a quick takeaway that It is originating from the hypoglossal nucleus, motor and exit from the hypoglossal canal. Branches are 4: meningeal, descending, thyroid, and innervate only the muscle. The palatoglossal, that means the tongue muscles, helps what is the function of the tongue, like speech, swallowing, and deglutition and the tongue movement. And clinical lesion can cause tongue deviation, atrophy, and fasciculation. So that is my slide presentation.
Thank you, Dr. Farah, for this
Thank you, sir.
presentation. It's a very nice presentation. So I'd like to welcome everyone for the 17th and the final webinar of the comprehensive neuroanatomy educational program that organized by the Yemeni Neurosurgical Society, World Federation of Neurosurgery, Young Neurosurgery Forum, and Neurosurgery Coach, and Neurosurgical TV, and Pakistan Society of Neurosurgeons. We already had our first presentation with Dr. Farah Anjam, who gave us a presentation about anatomy of the 11th and 12th brain and nerve, and very nice presentation. For questions, we will be at the end of the program. So, Dr. Abdul Latif, please, you can introduce our next speaker. Please unmute, Dr. Abdul Latif. You are muted.
Now you listen me.
Yes, sir.
Yes, we can hear you.
Thank you, Dr. Ahmed. Thank you, Dr. Farah, for this nice and important lecture for young neurosurgery and residents. And we have a pleasure to invite Dr. Yasser Hashim from consultant of neurosurgery from Hyderabad for next lecture about advanced imaging of brainstem and cranial nerves. Please, Dr. Yasser, you listen me?
Yes, I can hear you clearly. Dr. Latif, thank you very much for the pleasure.
Welcome, and we are happy that we are in this nice and important lecture. Please start if you can.
Yes, sure. Can you see the screen? Is it zoomed?
Yes, we
Not
see it,
yet
but if you
zoomed.
can make it on presentation mode, it will be better.
Yeah, is it clear now?
Yes, perfect.
Okay, okay. Thank you very much. I'm thankful to Yemeni Neurosurgical Society and the Young Neurosurgery Forum of the WFNS for giving me this chance to present the advanced imaging anatomy of the brainstem and the cranial nerves. I would like to start with a few cases over here. On your screens, you can see this MRI. This is the T2 axial image. And this patient actually presented with the left-sided facial pain that was within the region of the V2, V3 divisions on the left side. And I hope you can see this MRI is taken at the level of the pons. You all can appreciate this structure that is going anteriorly arising from the pons. This is the nerve which arises from the pons, that is the trigeminal nerve. We can see this hyperintensity over here. This is suggestive of Meckel's scale. So this is the pathological MRI. We can also appreciate over here that there are a few structures, vascular structures lying just above this nerve. So this patient actually had a trigeminal neuralgia on the left side and caused by the obstruction caused by a vessel over the exit zone of the trigeminal nerve. This was the superior cerebellar artery. So another case is in front of your screens. This shows again a T2 axial image. This time it's taken at the level of the cochlea and at the level of the lower pons again. You can see this structure that is going towards the cochlea would be the vestibular nerve. If we compare the right side with the left side, we can appreciate that there is a difference on the both sides. On the right side, we can see the nerve going clearly, whereas on the left side, we can see that the nerve is being displaced by another structure. So again, a pathological image. This patient presented with left-sided hemifacial spasms. In this case, it is the anterior inferior cerebellar artery that is causing the compression. And then this is the third case. I will leave it over here. In this case, we've got the coronal images of the T2. We can see the flow voids caused by the internal carotid artery. So this is the internal carotid artery. The problem here is that the patient had actually visual symptoms. The patient has got a left-sided visual blurring. And in this case, there's again a case of the vascular compression. This vascular compression is actually caused by the anterior cerebral artery. You can see in this angiogram, this is the anterior cerebral artery arising from the internal carotid, going to the contralateral side over here, and then going back again on its side. So it takes a loop from right side towards the left side, causing sandwiching of the optic chiasm in between the internal carotid artery, the supraclinoid portion, and the acid. Again, leading to the compression of the optic chiasm, being seen over here is this hyperintense signal. So there were three cases. I took them from the internet. I have mentioned the source. So the first one was of a left trigeminal nerve, another one of the left facial, the hemifacial spasm, and the third one of the optic chiasm compression by a tortuous A1 segment. So this shows why it is important for the neurosurgeons to be competent within the field of the neuroradiology as well. So with this, now let's begin. I have divided today's session into two sections. The first one is mainly concentrating on the brainstem anatomy, and then we will be looking at the cranial nerves as well. So all of you know about the brainstem. This small structure lying over here is the brainstem. Hardly constitutes only 2.6% of the total brain's weight, but very important for various reasons. First of all, it's a connection between the cerebrum and the spinal cord, and the cerebellum connects the whole CNS. It's also housed to the various cranial nerve nuclei. Other than the optic and olfactory, all the cranial nerve nuclei reside over here. And then it's the stem of life. Why it is the stem of life? Because all our cardiorespiratory centers, all our vascular centers, even the reticular formation, which is important for arousal, lies over here. So this is divided into various categories of triads. It has got three parts, we know them, but it has also got three layers. What layers are those? One layer is this anteriormost layer that is known as the basis. This mainly deals with the motor function. Then we have got this layer that is the tegmentum. And then finally, we have got this posterior layer that is the tectum. The tectum is located only at the level of the midbrain, whereas basis and tegmentum run entirely through the midbrain, pons, and medulla oblongata. So three parts, we know about it. How do they appear on an imaging? So if you look at the axial imaging, midbrain takes on the shape of a Mickey Mouse. Just to remember, you can see these elongated cerebral peduncles, also known as the crus cerebri. They are elongated outward, fan outward with a space filled with CSF in between. This space is the intercrural cistern, or the space between the two crura, or the crus cerebri, or the cerebral peduncles of the midbrain. Then we have got pons, whose foreface is just like the belly of a fat man, protruding outward, broad. And then we have got medulla oblongata, like a butterfly on the axial sections. Two mounds in front, two legs kind of behind. These mounds are the pyramids which Dr. Farah was just describing in her presentation. So three layers I already described: the tectum, the tegmentum, and the basis. So how do these three layers look on the axial imaging? You can see this is the basis or the basal, which corresponds to the basal plate embryologically. Embryologically, embryo has got a basal plate and an LR plate. Basal plate is mainly motor, consists of motor functions, whereas the LR plate is mainly sensory. So you have the basal plate corresponds with the basis. The basis is small in the midbrain, compact structure. Then it spreads out within the pons, again compact within the medulla oblongata. Whereas the tegmentum, which corresponds to the LR plate, which consists of sensory pathways, and also the cranial nuclei, is more so occupying the most portion of the midbrain, small portion within the pons, again most portion in the medulla oblongata. But the tectum lies only at the level of the midbrain. So functions, we talked about it, the stem of life, various cardiac, respiratory centers are here, it connects, it houses. The reticular formation, which is important for arousal, lies over here. And then this picture about the connectin, I would like to take some time to describe this image. This is actually a diffuse tensor imaging. In this, you can see various fibers, more so various tracts. We know already about the color coding of these tracts. DTI used to construct the tractography, very helpful when we operate on a patient. We know in which areas we should go, how to avoid the important tracts that are traveling in that area or displaced by the tumor. The coding is like when there is blue, it travels from above downward. Like if take example of a corticospinal tract arising from cortex has to go into the spinal cord, it would come as blue on the DTI. If you take example of the red fibers, these are the commissural or the crossing fibers, which go from left to right. So you can see the corpus callosum is red, for example. And then the green fibers actually travel anteroposteriorly, like they are taking command from the frontal portion of the brain to the parietal lobe, then they would be green. So again, the motor pathways, various motor pathways travel through the brain stem, corticospinal, corticobulbar. Corticopontine is an important fiber which travels from cortex to pons to cerebellum, and then various sensory pathways as well. So again, this is a picture of an axial T2 MRI. Now, this is a pathological picture. You can see that this patient has got a left-sided MCA infarct. So why I'm showing you this? I'm showing you the anatomy by pathology. We know from the corticospinal tract actually arises from the cortex or from the gray matter, and then these fibers travel all the way to the spinal cord. When they come at the level of the midbrain, they travel via the crus cerebri, the most anterior portion of the crus cerebri, that is the basis, houses these fibers. You can see in this patient actually had an MCA infarct, but also on MRI imaging, the same patient is showing degeneration of the left-sided crus cerebri. This is actually due to the Wallerian degeneration. So when the cell bodies are dead because of the infarct, the axons tend to degenerate in the same patient. So this also gives the proof that these fibers travel through the crus cerebri of the midbrain, then through the bases of the pons or pontine bases, and then finally through the pyramid of the medulla oblongata. You can see that right-sided pyramid is normal, whereas left-sided pyramid is atrophic. So this is an example of the Wallerian degeneration of the corticospinal tract. Again, in this picture, you can correlate the anatomy of the pons on an DTI image, or you can see that anteriorly, we have got this corticospinal tract blue. In between, we have actually got the pontocerebellar tract, crosses from the pons on the one side to the cerebellum of opposite side. So it's red. Then posteriorly, we have got ascending pathways like a spinothalamic tract, again blue. So corticospinal tract, medial lemniscus is a part of the dorsal column medial lemniscal system. So this is showing the base of the pons, and pontocerebellar fibers which travel from pons of one side to the cerebellum of other are red. So we discussed about the cerebral peduncles or the crus cerebri. These are actually the projections of the midbrain. Then what are cerebellar peduncles? See, there's a difference between cerebral and the cerebellar peduncles. Cerebellar peduncles are actually the three peduncles of the cerebellum, sorry. Three peduncles of the cerebellum which connect it with the brain stem. So there's a superior cerebellar peduncle, there's a middle cerebellar peduncle, and there's an inferior cerebellar peduncle. So in this figure, we are showing you a CPC pathway. Like these are the frontopontine fibers, come from the cortex, frontal cortex to the pons. And then from pons, another fiber arises, that is the pontocerebellar, which travels via the middle cerebellar peduncle to the cerebellum. Then there's an inferior cerebellar peduncle, which connects the cerebellum to the spine. The spinocerebellar tract come from this. And then we have got the superior cerebellar, which is the only efferent pathway of the cerebellum. So superior cerebellar peduncle goes from cerebellum towards upward. So this is the same thing that I just described. But how does the cerebellar peduncle appear on the imaging? That is what our main topic is. So you can see this cut section of the MRI at the level of the pons. You can see these small area, small peduncles that are connecting it with the cerebellum. In between, you have got the fourth ventricle. This is the superior portion. So these two small peduncles are actually the superior cerebellar peduncles. You can see that this is the cut section where it has been taken on the sagittal image. This is the superior cerebellar peduncle. So now highlighted in yellow. On the second picture, you can see this large broad area connecting the pons to the cerebellum. This cut section is at a slightly lower level, and this is the middle cerebellar peduncle. And then finally, in this third picture, though inferior cerebellar peduncle are very difficult to be appreciated on the MRI imaging, they are very small, but we can say that this is the region where the inferior cerebellar peduncles would usually be located at the level of pontomedullary junction. Now, the cranial nuclei that lie within the brainstem. See, there's always a rule of 4. We all know about it. First 4 above the midbrain, above the level of the pons. Then 4 nerves arise from the pons. Then 4 below the pons from the medulla oblongata. Something about embryology, why I have put it here, you have to understand the concept of the basal plate and LR plate. Normally, this is how the embryo is. This is the dorsum. This is the front. So on the dorsum, you have got this LR plate. And on the front, you have got this basal plate. But what happens that these LR plates are pushed laterally, they tend to come outwards. So LR plate leads to the sensory nuclei. So sensory nuclei would be located laterally and the motor nuclei would be located medially, because that is how the formation of the brainstem occurs. The fourth ventricle widens out, pushing the sensory nuclei laterally. So again, an example of various motor nuclei that lie over here. I do not like to go into the detail because obviously we are short of time. Extremely sorry. Okay, so now this is a cross section of the midbrain. So what nuclei normally lie at the level of the midbrain? At the level of the midbrain, we have got the Edinger-Westphal and oculomotor nuclei. We have got the trigeminal nuclei. At the lower portion of the midbrain, we have got a little trochlear nuclei. And then we have got the mesencephalic nuclei of trigeminal nerve. And then about pons, it would be more better if we correlate this with imaging. So let's see the imaging of the anatomy of the midbrain. So this is the midbrain. You can see the axial T2 cuts of the midbrain. This is where the imaging has been taken. So most anteriorly, we have got these crus cerebri. This is the basis part of the cerebrum. This is the crus cerebri portion of the midbrain. Sometimes on T2 images, the red nuclei that lie just posteriorly are easily appreciable as hypointense areas. So we can say that this is the region of the red nuclei. Also in the center, this small CSF filled space can be seen. This is the aqueduct of Sylvius, which lies within the midbrain. Just around the aqueduct of Sylvius, we have got this hyperintense area. This is the periaqueductal gray matter. Now, how do we localize that where the oculomotor nerve nucleus would be located? First of all, this is the upper portion of the midbrain at the level of the red nucleus. Okay. Then just anterior to this periaqueductal gray matter, like this is the central aqueduct of Sylvius, this is periaqueductal, we have got the nuclei of the cranial nerves. So we cannot see the nuclei themselves. But if there's a lesion present, we can say that just anterior to the aqueduct of Sylvius, we have got the oculomotor nucleus, both the motor and the Edinger-Westphal nucleus. If we come at a lower section of the midbrain over here, we have got this posterior medullary vellum that helps us identify. And over here, just anteriorly, we have got the inferior colliculi on the both sides. And this is the level of the trochlear nerve. We cannot again see the trochlear nucleus by itself, but sometimes we can appreciate the thin nerve arising dorsally. So this is how the presentation is in an schematic diagram at the superior upper midbrain level and at the lower midbrain level. But this is what we are interested in. This is the basis, this is the tegmentum, and this is the tectum. Tectum is also called quadrigeminal plate, and it comprises of the superior colliculi and inferior colliculi. What is colliculi? It's a mound produced posteriorly. Like this is the prominence produced posteriorly. The superior colliculi deals with vision and inferior one deals with the hearing. So lots of anatomy. Let's see what we can make of it on an MRI. This is a T1 weighted image. This is T2, and this is a susceptibility weighted image. Actually, SWI images are the most helpful because when there's an altered concentration gradient of iron, the structures become more visible. Like on this image, you can see this hypointense area of substantia nigra. So we can easily say just anterior to the substantia nigra, we have got the crus cerebri, and we have got the corticospinal tract running over here. And just behind it, we have got this red nucleus. So yes, this one is the substantia nigra, which is a part of the extrapyramidal system, and this is the red nucleus. This is the midbrain base, which contains the corticospinal tract. And again, this crus cerebri is further divided. If the lesion is located in the most anterior portion, the frontopontine fibers would be affected, and it's somatotopically organized, like homunculus in the brain. Even in the midbrain, there is somatotypic organization. The face fibers are located most anteriorly. So if a lesion is over here, patient will have facial palsy. And then the arm fibers, and then the leg fibers. This we have discussed. We already said that if we localize the periaqueductal gray matter, we can identify that where the cranial nerve 3 and 4 nuclei would be lying. In between the nucleus, red nucleus, and this aqueduct of Sylvius, we have got the nuclei of 3rd and 4th nerve. So like this example of this patient has got a small hyperintense area, small hyperintense lesion over here. This is actually an infarct, and the patient presented with the left oculomotor palsy. So see that when the lesion is just anterior to the aqueduct of Sylvius on the left side, the imaging corresponds with the clinical picture of the patient of oculomotor palsy. But in this case, the lesion is not at the level of the nucleus itself. It's slightly anterior, near the crus cerebri. But again, the patient has got an oculomotor palsy. Why? Because this is the pathway that is taken by the nerve within the brain stem to come out. So that is why because of the lesion, there is edema, and patient has got this palsy. So this we discussed, the cerebral aqueduct, the periaqueductal gray matter, the tectal plate. Now, this is the anatomy, radiological anatomy of the tectum being described. You can see the tectum over here. If we go slightly laterally at the level of tectum, we have got the superior and inferior colliculus, the bulges produced. On a coronal section, they form a four-sided mound like this, a butterfly shaped, two superior colliculi, two inferior colliculi. And on the axial imaging, you can see these bulges. At the superior level, the superior colliculus, which deals with the visual reflex pathway, and the inferior colliculus, which deals with the hearing reflex pathway. Just behind this tectal plate is the pineal gland. So again, if we take example of a lesion, like this lesion, this hyperintense lesion, you can see that this lesion is located below the corpus callosum, displacing the crus cerebri anteriorly, causing compression of the tectal plate. Actually, pineal gland neoplasm over here. So the tectal plate would be compressed, leading to the symptoms of the Perinaud syndrome, that vertical gaze palsy would occur. So this is the nucleus of the oculomotor nerve. You can see how the nerve arises from the oculomotor nucleus, comes anteriorly out of the crus cerebri, and this is the nerve exiting within the intercrural cistern. Whereas on the lower midbrain level, you can see the trochlear nerve nucleus. The important thing about the trochlear nerve is that it is the only cranial nerve whose nerve exits dorsally from the brainstem. All the nerves come ventrally. This is the only cranial nerve that exists dorsally, and also the only cranial nerve which crosses onto the opposite side. Like a left-sided trochlear nerve nucleus would give rise to the right-sided trochlear nerve. So this is the trochlear nerve coming out. So again, in this image, if you look closely, you can appreciate there is this hypointensity at this level, which is also enhancing. So this is the example of a oculomotor schwannoma. The patient had a left-sided oculomotor nerve palsy. So imaging is always important. Not common to find these ones though. So pons, again, let's escape this detail. But in this detail, I would just like to bring your attention to one thing. Note, this is the abducent nerve motor nucleus that is located posteriorly just into the floor of the fourth ventricle. We all know that floor of the fourth ventricle is important because most of the cranial nerve nuclei lie over here. And we all have heard about the facial colliculus. So this is the facial nerve nucleus, the motor nucleus of facial nerve. This is the abducent nucleus. We see that the facial nerve axons before exiting the brainstem form a loop around this nucleus, then come out. So this produces a bulge into the floor of the fourth ventricle. It is known as the facial colliculus. This is important. It consists of the nucleus of the abducent nerve, fibers of the facial nerve. So again, pons has got this basis within which we have got the motor fibers. It has got this tegmentum in which there are cranial nerve nuclei. So see, in this imaging, you would say that we cannot find much on the pons imaging. We cannot identify many things on simple T2, but if we look closely, we can. As I previously told you, these are the superior cerebellar peduncles, okay? So this is the upper level of the pons. This is not midbrain because superior cerebellar peduncles are present. Then if we come downward, we can see that there is this nerve coming out on both sides. This is the trigeminal nerve that is coming out. And it's going towards this small hyper-intense cave. That is the Meckel's cave. CSF filled. And again on this cut, just when the pons is getting ended at the lowermost cut, we can see this nerve coming out on both sides. This nerve is going into the air. And then in the region of the air, we can identify this cochlea. We can identify these various semicircular canals. We can clearly say this is the vestibulocochlear nerve. So there are various structures that can be identified even on the anatomy of the pons. What I missed was this facial colliculus. You can see that at this level, where this Meckel's cave was located, you can see this protrusion protruded into the floor of the fourth ventricle. These two dumplings are actually the facial colliculus, and here would be the abducent nerve nuclei. Also, there are two large peduncles on both sides. I previously told you these are the middle cerebellar peduncles. So again, a detailed image of this level, showing the facial colliculus, showing the location of the abducent nerve nucleus, showing how the facial nerve nucleus is located slightly anteriorly, and it loops around this abducent nerve nucleus before exiting. So various cranial nerves on enhanced imagings. Here you can appreciate the vestibulocochlear nerve going within towards the cochlea. You can also appreciate the abducent nerve. The abducent nerve tends to arise inferiorly and then travels upward. So this is the inferior most cut, and you can see that anteriorly this small black structure is the abducent nerve. Over here, this is the region where the abducent nerve is present, and this is the abducent nerve. So abducent nerve tends to arise inferiorly, then travels upwards until it enters into this Dorillos canal. If we have time, we will discuss it later as well. And this is the facial nerve. So again, this is the abducent nerve that has arise from the pontomedullary junction, and I'm going from medial to lateral, and it's traveling upwards on the clivus towards the Dorillos canal. So a little bit of pathology of the pons. So what's wrong in this image is that you can see that here the facial colliculus is absent. This is a case of a genetic malformation in which facial colliculus is usually absent. So abducent nerve nuclei is not properly made. That's why the patient has got a horizontal gaze palsy. Mobius syndrome is a condition in which there's congenital absence of the facial colliculus along with the facial nerve nucleus as well. Then internuclear ophthalmoplegia is a condition in which medial longitudinal fasciculus is involved. So I won't be going into its detail. This is the case of a small cavernoma in the region of the right abducens nucleus. You can see that this is the facial colliculus, and just anterior to it, we have got this small cavernoma over there. Patient has a history of developing acute diplopia. Then comes the medulla oblongata. Within the medulla oblongata, we have got centrally these two protrusions that are the pyramid. And then laterally, we have got another protrusion produced by this inferior olivary nucleus. This is known as the olive. In between the olive and pyramid, we have got one sulcus. This is the pre-olivary sulcus. And behind olive, we have got another sulcus that is known as the post-olivary sulcus. So this is the T2 weighted image at the level of medulla oblongata, butterfly shape. You can see these two pyramids. And then you can see the olive. And again, this is the pre-olivary groove. This is the post-olivary groove. So this is what you can appreciate on the anatomy of the medulla oblongata. In the center, we have got anterior median fissure. So why was this pre-olivary, post-olivary important? Is because cranial nerves, when they arise, they tend to arise from different region. You can see that the glossopharyngeal nerve, accessory nerve, vagus nerve, they tend to arise from the post-olivary groove. So this is the pyramid, this is the olive, this is the post-olivary groove, this is the nerve arising. Going to the jugular foramen, pars nervosa portion, and then exiting the skull base. Whereas from the pre-olivary groove, we have got another nerve arising, that is the hypoglossal nerve. So this is the pyramid, this is the olive, this is the upper level of medulla oblongata, this is the lower level, and at the lower level you can see the hypoglossal nerve arising, going towards the hypoglossal canal. This is the course of the hypoglossal canal that has been traced over here, and this is the course of your glossopharyngeal vagus and accessory nerves. So, well, this is another example of imaging appearance of a glioma within the level of the medulla oblongata, causing prominence of the pyramid on one side, on which the glioma is actually present. Okay, so Wallenberg syndrome, I'm not going to describe it. So now let's come to the cranial nerves. Imaging sometimes is very helpful even without the context of the clinical history. If you look at the imaging clearly, you can identify various pathologies. Like example of this CT, these are the periorbital muscles. If you look closely, muscles are well developed on one side and atrophied on the other side. This gives a hint to the congenital left oculomotor palsy. So if we look at the imaging clearly, we can identify the pathologies even from imaging. So few cranial nerves were left out of the course because we are talking about brain stem. So this is the example of the olfactory nerve. This is where the olfactory nerve travels. If we trace it from above downward, we will identify the gyrus rectus, and just medial to it, this is the olfactory nerve. Similarly, on this cross coronal sections, it is more easily visible. This is the reveal of the gyrus rectus, and this is where the olfactory nerves are located within the cribriform plate. So again, you can see the gyrus rectus, and just medial to it, between the orbital wall and the gyrus rectus, we have got the olfactory nerve. Then the optic nerve, it has got various portions. It has got intraorbital component. It has got a cisternal component as well. They got a canalicular component as well. This is the optic nerve traveling all the way. Then we have got the optic chiasm, and then finally the optic tract. So these oculomotor nerves we already described, but a little bit of more detail about them. Like we described all the oculomotor nerve, but we did not describe about these vascular structures which are in the vicinity. So in the intercrural system, you can appreciate this is the basilar artery. And then this nerve actually exists between the posterior cerebral artery and the superior cerebellar artery. So this nerve can actually be easily compressed between the aneurysms of these vessels as well, because it tends to travel in between them. So this is important clinically from a neurosurgeon's perspective. So again, this is the picture of the trochlear nerve. You can see it arises from one side, travels all the way to the opposite side. What what is the important thing about the trochlear nerve is that trochlear nerve is a very thin nerve. And when it's traveling through this ambient system, it's actually lying just medial to this free edge of the tentorium cerebelli. So it can easily be compressed in the cases of the trauma or increased ICP over here. So abducent nerve nuclei, we discussed this already. So not going into its detail, this is the abducent nerve. This is an important picture, again, a coronal cross section of the oculomotor nerve. In this coronal cut, you can see this vascular structure. This is the basilar artery. These are the superior cerebellar arteries. And then finally, basilar is dividing into two posterior cerebral artery. And in between this posterior cerebral and superior cerebral artery, we have got this our nerve exiting, which is the third cranial nerve or the oculomotor nerve. So that's why it can be easily compressed. This I just described to you that this trochlear nerve can easily be compressed between the free edge of tent and the midbrain in cases of trauma. Again, abducent nerve, we went through it. So this abducent nerve, before exiting, it tends to enter into the Dorillo's canal. So let me just give you a hint about what is Dorillo's canal on an MRI. Dorillo's canal is actually a dural lined channel. You can see the CSF rim over here. When this abducent nerve arises from the brain stem, it tends to travel within the system along the clivus. And when it reaches the petroclival junction, this is the petrous bone, this is the clivus. You can see clivus, petrous bone, just near the petroclival junction. Here it enters into the dural filled canal known as the Dorillo's canal. So within the Dorillo's canal and the brainism, it's tightly adhered, the abducent nerve. So any trauma that tends to cause compression can also damage the abducent nerve, leading to the abducent nerve palsy. So the fifth cranial nerve, the trigeminal nerve. The trigeminal nerve tends to arise from the pons, then tends to travel anteriorly straight forward, tends to insert this CSF filled space, it is the Meckel's cave. It's important because any vascular compression within this region can cause the trigeminal neuralgia, as I described in the beginning. A little bit about the cavernous sinus as well, because unfortunately these cranial nerves travel through this sinus. You can see on this contrast enhanced imaging, this is the pituitary, and on both sides we have got this contrast enhancing cavernous sinus. So on this coronal cut, you can see the pituitary, you can see the stalk of the pituitary, you can see the optic chiasm. On both sides, you have got the flow voids of the internal carotid artery. Now, why we have come here is because this cavernous sinus, wall of the cavernous sinus consists of various nerves. The third, fourth, VA and V1 and V2 travel within the wall of the cavernous sinus, whereas the sixth nerve lies just laterally and inferior to ICA within the center of the cavernous sinus. So sixth nerve is most susceptible to the injury or the involvement of the cavernous sinus by a thrombus or anything. You can see this image. This is the pituitary. This is the ICA. And let's try and localize the various cranial nerves over here. You see this nerve, and this nerve over here. So the nerve which lies just above ICA is the third cranial nerve. And these nerves which travel within the wall would be V1 and V2. And in between here would be the location of the trochlear, though it's not usually appreciable. And even the sixth nerve is visible in this case over here. And this sixth nerve is again usually not visualized on the MRI imaging. But the nerve which we can easily identify in MRI is the third cranial nerve. Why? Because third cranial nerve actually brings a CSF lined jacket with it. That's why it's usually hyper intense when we look at the imaging. So usually if you look at the region of the ICA on a coronal cut, third nerve could easily be appreciated. Finally, these nerves exit via the orbit between the greater sphenoid wing, lesser sphenoid wing. This is the optic canal, and then they supply it. Seventh and eighth, I described a little bit about it previously as well. They tend to arise from the pontomedullation, travel to the internal auditory meatus. A little bit more detail about the anatomy of the internal auditory meatus. The arrangement is very specific when we look at the internal auditory meatus. It is divided by the Bill's bar. And usually the facial nerve is located anteriorly, and just below it is the cochlear, and posteriorly we have got superior and inferior vestibular. So there is even a mnemonic for it called 7 up, coke down. So 7 is up, cochlear is down. Then again, this image shows the 9th and 10th cranial nerves, previously described about it. And then this is what Dr. Farah just described today. The spinal fibers of the 11th nerve arising, the spinal portion arising from the level of the spinal cord, and then at the level of the cervicomedullary junction, we have got these cranial part, and then they finally join together. And finally, the hypoglossal nerve. One point to localize the hypoglossal nerve is by looking at these vertebral arteries and posterior inferior cerebellar artery posteriorly. Between the vertebral artery and pica, you usually have this thin nerve, that is the hypoglossal nerve, going towards the hypoglossal canal. So this is what I described in the beginning. And with this, I would like to conclude my presentation. Thank you very much. Yes, any questions?
Thank you very much, Dr. Yasser, for this fantastic presentation and very nice explanation of the radiological anatomy of the brainstem and cranial nerves. Thank you very much. Also, that you have a very short notice for the preparation of the presentation, but you did a very great job. Thank you very much.
Yes, my mentor called me 2 days back for this presentation, and then I'm always glad whenever he asks me. I have been very grateful to him. He's a wonderful teacher, Dr. Salman, and he has always been helpful to me. It was the least we could do. And thank you very much for this opportunity as well, Dr. Ahmed.
Thank you very much. So, Dr. Abdul Latif, do you have
Thank you, Dr.
any?
Yasser, thank you, Dr. Yasser, for the nice lecture. And we can add the advanced imagine of brainstem. It help us for know subtype of tumors of brainstem and the prognosis of tumor.
Yes,
Dr. Yasser?
Yes, I'm listening.
You listen me?
Yes, I listen to you. You are asking about can the imaging help us in the prognosis of the tumors? Am I right?
Yeah, the prognosis and the subtypes of tumors of brainstem.
Yes, obviously, when we talk about the brainstem, the prognosis is usually guarded, as we all know. But this imaging would help us to preoperatively localize it. How should we approach our tumor, or how should we plan our approach as well? Like, there are certain areas of the brainstem in which we usually do not go. There are safe corridors as well. But if we look at the imaging in detail beforehand, then it would obviously help us localize the vital structures and address them as such. Moreover, the cranial nerves localization, especially in case of vestibular schwannomas, would help us preoperatively localize where the facial nerve is. But we know from our practice that usually on MRI, we are not able to localize. We know that it's usually pushed anteriorly. So that is the thing. If you want to add something, maybe you can add as well.
Okay, thank you, Dr. Yasser. Thank you. Dr. Ahmed?
Yes, we had one question from one of the participants, one of the attendants. When you explained the aqueduct of Sylvius at the anatomy of the axial cut of T2 imaging, that it was looking black. He was asking why it's looking black, not white, in T2.
In T2?
Yes.
No, it must not have been T2. CSF by definition is always white on T2. It would have been
Yes.
some other image. That's why it was black. It could have been T1 image. That's why it was black. So by definition, we know that CSF is always hyper intense on T2. So maybe
Yes.
during my presentation, I said T1 or T2 by mistake.
No, it was T2. It was T2 image, axial cut, and it was a small black dot that you interpret as the aqueduct of Sylvius. I think could it be the lining of the aqueduct that give it that appearance?
Maybe because it was very small, that's why it was appearing as such. I don't know. But obviously, we know that the CSF is always bright
Yes,
on
it's
the
white.
Yeah.
I
Yes,
know
it's
that.
white. Yeah. So,
Okay. So if anyone of the attendants have any questions, please you can ask in the chat or you can ask also directly. Otherwise, if there is no any questions, we can conclude the session. Dr. Abdul Latif, do you have any remarks or
Thank you.
questions?
Thank you. No question another. And we see our residents and college doctor of there is any question for Dr. Yasser?
We have some question from Dr. Mu'tasam Al-Asali. He's asking about from radiological point of view, please, what are the difference between CISS and Fiesta protocol in simple terms? He asking about the sequences of the MRI imaging, the Fiesta sequence and the CISS sequence. If you have any.
Fiesta sequence we usually use for the cranial nerve localization, and on the Fiesta sequences, the cranial nerves are usually very easily localized. The CIS sequence is usually used for the CSF flow, more so in the case of the Chiari malformation when we want to localize the CSF flow, whether there is CSF blockage or not. That's where we usually utilize the CIS sequence. Another difference is that Fiesta actually uses the CSF as a contrast itself. So it's an imaging in which we alter the color of the CSF lining around the nerves so that the course of the nerve becomes more pronounced. So it's kind of a terminology that in these Fiesta images, the CSF is actually used as contrast. Whereas CIS imaging is particularly used when we want to see that there is any obstruction to the flow of CSF or not, like in the case of Chiari malformation or so. So the Fiesta is more recommended when you want to look for the nerve pathology, especially in case of the trigeminal neuralgia or such cases. And if you like to add anything, please do.
Thank you very much, Dr. Yasser. Very well answered. Okay, if anyone else have any question, please, you can ask either in the chat or you can ask directly. I guess there is no more questions. So thank you, Dr. Yasser, for this very nice presentation. And also we thank Dr. Farah for her presentation. She already left because she had a call. So by this, we can conclude our 17th and final webinar of the Comprehensive Neuroanatomy Education Program. And inshallah, the certificates for speakers and for attendance will be prepared in this week or next week maximum. And for module 4, inshallah, it will be prepared, the schedule, and we should start, inshallah, at January, inshallah. So thank you everyone for attendance and for participation. And thank you, Dr. Yasser, thank you, Dr. Abdul Latif, and thanks to all the attendees. And also special thanks to Dr. Salman Sharif, who always support education activities, either in Yemeni Neurosurgery Society or WFNS societies and other societies as well. So thank you all and see you all, inshallah, in next program, module 4, inshallah.
Thank you very much, Dr. Ahmad,
everyone.
for you and for our college, Dr. Yasser and Dr. Farah, and for all college in this lecture. Thank you, and we see our college in our 7th Congress in Yemen next year, inshallah.
Inshallah. Thank you, and see you.
Thank you so much.
Okay. Thank you very much. See you.